Souls. Thank you very much for coming along. So I'm Professor Mitch Dowsett. I'll say a few more words about me and what my role is after I've given you the essential information that Mark has given me to go through here. So attendees should note their closest fire escape. There's one exit to the back of the lecture theatre and two at the front. And should the alarm sound, follow the guidance of staff who will make themselves known. Mark? Good. Toilets are available on the ground floor, on the first floor. We are recording all of the presentations, and that's only the sound recording. And all attendees, you will be emailed when these are uploaded onto the BRC website. You should have a feedback form, and that's really important to us. I know sometimes that can be a nuisance filling that in, but please do complete it. It does make a real difference to how we hold these events. You also have note paper and post-it notes, and a critical key part of what we're doing tonight is the 20 minutes discussion at the end. So this is to make sure that any of you that feel a bit shy and don't want to be identified by your face, just hand those in, and we'll actually I'll coordinate those and try to actually put them together and collate them into single questions in some cases. Sorry you've not had a cup of tea so far. The thing is, we're not allowed food or drink in this lecture theatre. And in past events, we've given people a cup of tea and then said, well, you've got to leave it outside now. It's time to go. But we do have a break in 40 minutes time for 20 minutes, and hopefully you can hold off till then. There is a Future of Cancer hashtag. If you tweet about the event, we'd like you to use that, and that's somewhere on one of these slides, I think, behind me. Okay. And the, where are we here? The @CancerBRC handle. These things mean little to me. I don't know if they mean much to you. Thank you very much also to the stall holders, and please do look at those during the breaks. That's Breast Cancer Care /Now, Royal Marsden Cancer Charity, ICR Engagement Team, Copperfield, the ICR Clinical Trials and Statistics Unit, and also our own Royal Marsden Patient Involvement Team. And it now says outline your role and the nature of the BRC, so I feel more comfortable now. So I say Professor Mitch Dowsett. I'm the so-called theme lead for breast cancer in our Biomedical Research Centre. So the National Institute of Health Research has a number of so-called biomedical research centres all around the country, and we're the only specialist cancer BRC, Biomedical Research Centre. And what this is all about is actually trying to align medical activities, oncology in this case, alongside expertise for basic research. And we're very fortunate here at the Marsden Institute of Cancer Research to have Breast Cancer Nurse Centre for breast cancer research, and many clinicians, oncologists, radiotherapists, scientists who are very keen to try to translate that work to early benefit for cancer patients. And that indeed is the role of the Biomedical Research Centre, and it's really the way in which we bring people together here using some of that funding. We really do want to engage with you. We want to both inform you, but be informed by you. Over recent years, I think it's reasonable to say there's been a sort of a revolution in the approach that we, medical practitioners, scientists, try to actually work with patients for the benefit of both of us. And in particular, were just an example, benefited greatly by the use of the voice group, my reads here today, Maggie Wilcox previously, in creating a protocol for taking biopsies from patients and actually managing patients with medical treatment for a short time before they go to surgery. That was really quite unusual, and their advice was critical in a successful trial, which was eventually done in 130 centres, involving nearly 4,500 patients around the UK. So you really can have an impact, both by your questions, discussions, and suggestions to us. So please do feel free and participate fully when we get to the discussion time. I've asked my colleagues here, illustrious group of presenters this evening, to try to really keep their time for 10 minutes each. We're giving you a real overview of the research we do here at the Marsden, from really the prevention side, early detection prevention, right the way through to the treatment of late disease. So real small but important aspects of that. If they go over 10 minutes each and I go over 20 minutes in discussion, the food's going to get cold. So I don't think any of us want you to upset you like that. So we will be trying to keep on time. And in fact, if I now move on to our first speaker, we might even get there early. So I think it's Minouk. Minouk is works just across the road here in the Institute of Cancer Research in the generation breast cancer now generation study. I'm sure you'll say quite a lot about that now.
Thank you, Mitch. All right. So that's my title. This is a map of breast cancer rates across the world. And it shows that breast cancer is predominantly a disease of countries with Western lifestyle. So the highest rates are in the USA, parts of Europe and Australia, and the lowest rates in parts of Africa, the Middle East and Southeast Asia. The question is, why? Some interesting insights have been given by studies that looked at immigrants moving from regions where breast cancer is least common to regions where breast cancer is most common. So breast cancer rates in Japan are very low. About 10 or just about maybe 12 new cases per 100,000 population per year. However, when Japanese moved to Hawaii after their birth, their rate of breast cancer was at least double. Now, Hawaii is a US state where, there's a much more Western lifestyle than in Japan. When the researchers looked at Japanese who were born in Hawaii, so they were born from Japanese parents, but they spent all their lives in Hawaii, the breast cancer rate was even higher. And this can be contrasted against the breast cancer rate among the non-Japanese Hawaiians that was higher again. Now, what does this tell us? That there is a very rapid change in breast cancer rates in one generation. And therefore, it cannot be due to genetics, because genetics doesn't change that quickly across a generation or two. So it must be related to a host factor, so factors related to the host country. And it also tells us that perhaps some of the risk factors are in childhood, because the women who were born in Hawaii have a higher rate than the women who were born in Japan and then moved to Hawaii sometime later in their lives. So what are the causes of breast cancer? How can we find out? And why do we want to know them? Well, we want to know them because if you understand the risk factors, we could hopefully use this information to aid prevention. So here at ICR, we're conducting a very large, long-running study. It's called a cohort study. And it's really focused on looking at breast cancer risk factors in women. It was launched in September 2004. And we recruited 113,000 female volunteers across the UK. And you can see here a picture of how many women contributed to from each region in the UK. At recruitment, they were aged 16 to 102. And the study included mother, daughter, and sister pairs. And that's why the study is called Generation Study. We owe an enormous amount to those women because every 3 years they fill in a very detailed questionnaire about their lives. And also, when they joined the study, they donated a blood sample. Women are followed up over time for breast cancer diagnosis. The study has already contributed, since its initiation, over 100 research papers, but we're hoping the study will run for at least 40 years with the support of our charity Breast Cancer Now. Here you see a picture of our recruitment questionnaire. There were 44 pages to it, so it was quite a job to fill that in. And logistically, it's also been a massive effort. So here you see those questionnaires being loaded on a trolley to go to the Royal Mail. So as you can imagine, we have a large admin team here in Sutton to work on this project. When the questionnaires are filled in and come back to us, they're scanned electronically and then archived in a large archive in our basement. And this is just one of the corridors you see on this picture. We also sent out blood packs to women so that they could go to their GP to have the blood taken. So all those blood packs had to be made up and then received by our laboratory and processed. They were processed so that they were split in little straws, so that if we need the material for a laboratory test, we only have to remove a small amount. And this is a picture of our tanks. They're liquid nitrogen tanks, which means they're extremely cold. And again, they're also stored in Sutton, as well as another off-site location, because obviously if there's a fire, we wouldn't want to lose it all. So what are we looking at? Well, we're looking at risk factors throughout life. So that's from childhood, birth weight, childhood body size, and pubertal factors, as well as adult height, weight and waist and hip size at various ages, and family history of breast cancer. We're asking about births, breastfeeding, oral contraception use, and menopause and HRT. And lifestyle factors such as alcohol consumption, smoking, your activity levels, and more novel risk factors that are often a little controversial, such as night shift work. Then we use the information from blood samples to look at genetics and hormone levels. And altogether, this becomes a very powerful design. What we're currently working on is the following. We're trying to make a personal risk score. And this is not only efforts from Sutton, this is actually worldwide. It's something that the scientific community really is active at doing. The kind of principle is as such. When the only thing we know about a woman is her age, we can only assume she's at average risk as for the population for her age. But if we had information on her family history, we can then start separating those women into women who are at somewhat higher risk because they have a family history, to women who do not have that, are at average risk because they do not have a family history. What we're trying to do now is adding more information. For example, information about the age at which a woman had her first period. Why does that matter? Because we've seen that women who have their periods earlier in life have a higher risk. We add information about age at first child. And that's because having a child earlier in life seems to be protective, and so on. By adding information on an individual, we start seeing a distribution of risk. With most women being towards the left, so that's a big green character there, that's why it sees bigger, but smaller minorities of women being at higher risk. So we're adding height and weight and menopause information and HRT use. And what we're working on here at ICR with the Marsden, as well as researchers in the US and Australia, is adding biological factors. And those factors are the following. The first one is breast density. This is information we can get from X-rays of mammograms. And here you see pictures of 6 different women from low density to high density. Density basically means how much white you see on the mammogram. And the white is breast tissue and the black is fat. So it's a ratio of tissue to fat that we're interested in. And we've seen from other studies that if your breasts are dense, your risk is higher. We also bring in information on hormone levels, such as estrogens, because we know that if you have high estrogen levels postmenopausally, your risk is higher. And thirdly, researchers have come up with a score looking at individual letter changes in DNA. There are about 300 different individual letter changes in your DNA that have been identified to be associated with risk. Individually, they have a tiny increase in risk, but if you add them together, which is called a polygenic risk score, so a score based on many genes, well, that score is a strong predictor of risk. So we're adding all this information to the information we have about from questionnaires. So what is the intention to do? What are we going to do with this personal risk score? The idea is that rather than just relying on age to inform us about somebody's risk, is to use this risk score and then to say, okay, from this risk score, you're at average risk. So we're going to give you general lifestyle advice and regular screening. If you're at moderate risk, well, maybe you'll be put on an intervention trial or intervention program of some form, and you'll be screened more often. And thirdly, if you're found to be at a higher risk still, you might receive counseling, even more frequent screening, and even be offered hormone therapy or risk-reducing surgery. So that's the idea. The last slide is the following, because you might be wondering, what about men? Okay, well, we know breast cancer can happen in men. However, for every 140 females diagnosed with breast cancer, there's one man diagnosed with breast cancer, so it's much more rare. So we can't use the design of the generation study to do that, to investigate the risk factors. So what we do instead is do a case control study. So over the last 10 years or so, our research team has been traveling around the country to interview men with breast cancer, as well as men who do not have breast cancer, but are similar in terms of their demographics, so that we can compare risk factors between the two groups. Our patients were diagnosed by more than 670 consultants, because a single consultant might just see a handful of patients, male patients, a year. So it's been a massive effort to get the permissions, as well as just identify the men. So the men were interviewed, and we have collected information about what we think might be risk factors, and they've also donated a blood sample. And some of the research related to genetic factors has already been released, but we hope that the first results on lifestyle factors will be released next year. The last thing I want to say is that we have a website. So the generation study can be found on this website, and we have a list of publications there if you're interested. So thank you.
Thank you very much, Minouk. That was great. We will be collecting questions from all of the speakers for the discussion at the end. I'm sure many of you will have questions around that area that Minouk's been going through there. Virtually everybody, I think, has got an interest in breast cancer is sort of an amateur epidemiologist. Most of us try to work out why does something happen, and Minouk's very much the person with her colleagues who actually tried to solve that puzzle for us. I should have said just one other thing during my introduction, actually. It's the 1st of October, of course, and this is the start of Breast Cancer Awareness Month, and we're delighted that we're able to time it for this evening and essentially launch the month for the Marsden Institute of Cancer Research in particular. So Minouk's told you something about how we're trying to identify better the patients, rather women, the risk in individual women. And we're now going to move on really to the topic of, well, how do we give that information to women, and how can we then use that information to perhaps try to reduce that risk? That's the key here. How do we actually try to reduce the risk and effectively prevent breast cancer? And we've got 3 presentations here, coordinated presentations. So I'm going to hand over to Katherine Krupa here, one of our surgeons that's got involved in this area very recently. Katherine. Oh, we're all coming up together. Good. Trio.
Good evening. Can anybody hear me? Is that okay? Yes. So I'm going to introduce my partners in this research. Carol Peaches, who is going to tell you more about herself, but I can say that she's a patient as well as a professional who's helping in this study. And the person who's doing most of the work, who's our junior surgeon, as they always do. And I'll tell you more about the rest of the team as we go along. So Carol first.
Thank you. Okay, this is going to be interesting. One of these, and notes. Let's see. Okay. So, Rebekah, Katherine and I are really excited to have an opportunity to talk to you about a project that we've been working on for around about the last year and is going to be coming to fruition literally within the next few weeks. So let's have a look and see what it is that we're so excited about. Now, that may look like a pretty grand intention, but when you think about the fact that an average of 55,000 women are diagnosed in the UK with breast cancer every year, you'll see that clearly there are a lot of women who we are looking to influence with the study that we want to tell you about, especially when you consider this. 23% of breast cancer cases are preventable. So for those of you who are as rubbish at mental arithmetic as I am, that means that actually there is an opportunity to look at 12,000 preventable cases every year. We may not know specifically which ones they are, but we do know quite a lot about the risk factors that are associated. And that's the fact that really galvanised all of us on the study design team. All of us really wanted to get involved in finding a way where we could influence women to want to understand their risk and not just know about it, but actually do something about it. So we pulled our collective knowledge and background and experience and opinions and set about designing a study that will hopefully benefit our participants at the same time as giving us an opportunity to learn from them. And that's all going to take place over the coming year. Sorry, excuse me, I'm fingers and thumbs. Can you do that for me, please, Rebekah? Thank you. No, I need that one, sorry. It was way more slick when I practiced this in front of the bathroom mirror earlier on. So, what we're going to be able to do is to tell our participants about some of their risk factors and present an opportunity for many of them to clearly identify the changes that they need to make in order to mitigate their risk. And to support that, we're going to be offering them a variety of information to help them make informed choices as to the changes that they may want to make. So, over the 12 months of what is actually a pilot study, we're going to be asking our audience to let us know what they find useful. So we want to know what we're doing well, and we also want to know what do we need to do differently in the future in order that we can really maintain people's motivation and empower them to make the changes that they need to make in order to reduce their risks. So my motivation for being on the study team is twofold. The first bit is because I'm, by profession, a learning and development consultant. And so for me, it's all about making sure that everything we do is as motivational as it possibly can be. So I'm the one that's crawling all over all of this stuff, making sure that it's as brain-friendly in terms of how we communicate and what we communicate as possible. My second motivation is fueled by my personal circumstances. So I live with secondary breast cancer. And when I reflect on the opportunities that studies like this present, I think about, okay, I know that there is no guarantees that if I'd have had an opportunity to understand my risk factors or to change some parts of my life, perhaps there are no guarantees that life would have ended up any differently for me. But I have to tell you that I definitely want to be part of offering that opportunity for others in the future. So, what we want to do moving forward is quite simply this. We want to learn how we're going to make the biggest possible dent in that number. So I'm now going to hand over to Rebekah for her to give you a little bit more detail about how we plan on doing that. There you go.
So, If I had my way, I would spend the next half an hour speaking in great detail about what we anticipate, if I had my way, every participant going through. But as has been highlighted, I have 3 minutes instead of 30 minutes, so I'm going to give you the whistle-stop tour. Wonderfully, 95% of the women who come to our new patient clinic are reassured and discharged home, which is brilliant. But they have still gone through all the worry, all the anxiety that comes with attending a cancer hospital for the first time. So what if we could turn that into something positive? What if, at the moment when we tell them we don't think they have breast cancer, we could also give them the tools to enable themselves to make lifestyle changes that would hopefully reduce their risk of developing breast cancer. That is our vision. So, we're going to take 240 women, just like that, and ask them to join our study. We'll give each of them a personal risk score, and we'll include genetics in half of those women as well. We're going to ask each of them to make a goal for the coming year, and we'll monitor their progress over that year. 2/3 of them will have access to the Pioneer website, which will take them through the goal-setting process, but also give them hints and tips about how to make changes to their lifestyle. And 1/3 of them will also have access to group coaching to help with that as well. And now just to say a little bit about myself, I've been part of the Pioneer team only for the last 6 months. I'm new to the party, as it were. But it's been a real privilege and wonderful opportunity to be part of this. Perhaps particularly because as surgeons, we're often a bit on the sidelines when it comes to research. Now, don't get me wrong, I love surgery. Being in the operating theatre, there is no buzz like it. But I reckon in the last 9 years of being a doctor, I've probably saved a handful of lives. But being part of this project, my hope, and I think it's a realistic hope, is that there will be thousands of women who are just going about their everyday lives, who never walk through our doors, never meet a breast surgeon, never meet an oncologist, and never have their case discussed at MDT. Because by being part of this study and future studies, we hope that there will be thousands of women whose breast cancer has been prevented. And so I'll pass on to Katherine.
So this slide is there just to tell you that every little bit matters. So every small change. Okay. So thank you very much for listening to us. As you know, we cannot do any clinical research without the participation of our patients. We are, as Mitch already said, very lucky to have the support of the Marsden and ICR to do the research. We've got all the academics here. Jenny Rasby, who's not here with us, but who's one of the researchers on the Pioneers team, certainly the academic brain behind the project. But in the Pioneers, we want to do more. We as Rebekah is saying, we're asking women who are not patients of ours to take part in this study, and also help us decide how best to move it forward. So really work with us, really collaborate to see how we can best deliver our very ambitious project. Because without the input of the participants, it won't work. We need to know what works best for all the women. So we want to learn from our pilot, and then very ambitiously we want to roll this prevention project out across the country. As Rebekah was saying, one arm of the study is to be web-based, so something that can be accessible to women everywhere. The project is going to be called Lioness. Another thing to mention, all of the lifestyle factors that Minouk has identified and other researchers that are important in prevention of cancer are also going to put us in good stead for prevention of other diseases, other cancers, heart disease, and so forth. There are also the same elements which are important for prevention of secondary prevention of cancer, so preventing cancer coming back. So one of our other ambitions is to use the platform we're developing for prevention or primary prevention, and also use the same material for women who want to reduce the risk of the cancer coming back. So if this sounds like an interesting project and you or family members and friends already want to put their arm up and say, yes, I want to participate, you can already register your interest at our website. That's for the Lioness study. And coming to the Sutton Breast Clinic soon will be pioneers. So thank you very much.
Thank you so much. That was great. Just a couple of things I'll say. One is that it's over 30 years ago, in fact, that the first pioneer of breast cancer prevention actually started a trial here. It was a photograph outside of Trevor Poll's. Some of you will know, actually standing alongside Ian Smith and myself at the Royal Marsden. Trevor started a trial of tamoxifen versus no tamoxifen or no other drug, placebo, and showed unequivocally that you could reduce breast cancer risk. But tamoxifen obviously isn't without its problems, and therefore it's not been taken up as much as one would hope. And it's been something of a hiatus in our research over the years, and it's a true delight to have our new set of pioneers going forward with really inspirational stuff. So thanks for that. The other thing it reminds me to say is that the reason the NHS gives us money to be a biomedical research centre isn't so that we can just do research in the Marsden, just do research in the Institute of Cancer Research, just improve the outlook for our patients. It's so that we can have impact across the country. What we're doing really does need to actually translate to improvements throughout. There's no justification for giving us the money unless it does. And therefore, I'm again delighted to see the ambition to roll this out elsewhere. And of course, the Generation study is one where you saw the impact across the country. So I'm now going to hand over to Alistair, one of our medical oncologists, and then on to Navita, radiotherapist, clinical oncologist, to tell us about latest therapy options for early breast cancer.
Thanks, Mitch. So, Alistair, can you come on Tuesday night and give a presentation about latest therapies for early breast cancer in 10 minutes shared with Dr. Somaiah? 10 minutes? I could be up here all night. Don't worry. So it's just 9 minutes to me and 1 for Navita. So, right. So I'm going to pick one setting, one small example. This could be replicated across lots of different settings of breast cancer, but just to give you an illustration of perhaps how we do things slightly differently now and how we might do things slightly differently in the future. So this is a breast cancer. This is a PET scan. It's not the routine way that we always look at breast cancers, but it's certainly the most colourful. So the breast cancer there, a lady lying on her back, sort of imagine sliced through the middle, lungs on either side, and a breast cancer over there, which unfortunately has already spread to some lymph glands. When someone's diagnosed with breast cancer, you should appreciate they have a biopsy. And this biopsy has been looked at under the microscope just by simple stains to look at the shape and the type of cells, and then stained for markers of sensitivity to certain drugs. And in this case, it's been stained for a marker called HER2, and this is a HER2 positive breast cancer. And we do this test because it indicates which drugs the breast cancer might respond to. And quite often when a breast cancer is of a relatively large size, spread to a lymph gland, and it's HER2 positive, we offer people treatment, drug treatment up front before the patient goes back to see a surgeon to consider an operation. And so this is an example of a lymph gland in a patient. before chemotherapy and got smaller after chemotherapy. So that's what we're trying to achieve. We're trying to push the cancer back, shrink it down prior to an operation. And we may be able to reduce the amount of surgery that is performed by my colleagues. Ultimately, the aspiration is my surgical colleagues will be out of a job because our treatment will be so good that we'll be able to clear the cancer completely and not necessarily need surgeon. Not quite yet, though. So, but the challenge is this. We know that whilst many women may get a very good response to their treatment, so the women in the blue line rather, and have a very low risk of their breast cancer coming back, unfortunately some women have a less good response and there's a higher chance of breast cancer returning. So what can we do to change that? What can we do to make more women in the blue line have a good response? And what do we do about the women with the yellow line who have a less good response to their treatment? 2 examples of how we've changed. So we need to increase the number of women having a good response. So we do this day to day in clinic. When I started out as an oncologist, as a consultant about 13 years ago, we just had the drug trastuzumab, but now we have another drug which is an antibody drug to that marker HER2 called pertuzumab or Perjeta. And what we do now routinely in women present with the breast cancer that I've shown you is we combine both drugs together, not just one, the trastuzumab, also called Herceptin, but this second drug, pertuzumab. Why do we do that? Well, because it increases the number of women who have a good response to treatment. So this is the proportion of women in whom the breast cancer has completely disappeared when they come to the time of their operation. The blue line is those women who had chemotherapy and the Herceptin or trastuzumab alone. The green bar is the proportion of women who had the same treatment, but with pertuzumab as well. So we've significantly increased the number of women who have a good response to their treatment and have a much better longer-term outcome. That is something we routinely do now, funded by NICE, routinely used in the clinic. But there are still some women, so if you like 30%, 35% on that slide, who despite the best possible treatment have not cleared their cancer. So what can we do for those women? Well, there is an amazing drug. Just pause about this, but this is incredible. Sorry, Navita, I'll just eat into your time. But look, there is a concept of using what are called antibody drug conjugates. And what they are is drugs like trastuzumab or Herceptin, but bolted onto that drug is a chemotherapy molecule. Okay, it's shown in a little red block there. And essentially what happens is that antibody attaches onto the cells on those bits that are stained brown on the slides and gets sucked into the cancer cell. And when it gets sucked into the cancer cell, the bond between this antibody and the chemotherapy is broken and the chemotherapy is released into that cancer cell. So it's a very specific therapy that's released specifically within cancer cells. That means it has a much lower rate of side effects in other normal tissues. And why this is important on these last 2 slides is this. This is a study that was presented very recently. It's a drug that's now, and this now hopefully will be coming into clinic and already has in some settings. These are patients who've had their chemotherapy up front, just like the patient I showed you. They have not had the response we wanted them to see. In other words, we wanted them. So they're the sort of 30% of women who didn't get clear of their cancer by standard treatment. And they were assigned in clinical research study either to receive the Herceptin alone or Herceptin and that new drug I just showed you called TDM1 or Kadcyla. And what happened was with the addition of the new drug, as opposed to carrying on the Herceptin alone, we increased the number of women who are cured by about 10+%. And this is already women, we've already cured a significant proportion of women with the chemotherapy up front. So this is, if you like, salvaging and trying to get better outcomes for those women who had a less good response to treatment. So I've given you 2 examples. One of how we're increasing the number of women whose breast cancer responds to treatment in the first place, but also how we might help those who have a less good response and tailor their therapy accordingly. Those are 2 examples, routine clinical practice and practice that's changing in one small setting. Got about 30 seconds left, Navita.
Thank you. I have to say, when Alistair sent me his slide deck, there was just one line saying, "Don't panic. It's 14 slides, but I will finish in 5 minutes." So I've got the next 5 minutes to tell you about what's new and exciting in radiotherapy. So in the next 5 slides, I'm going to give you a flavour of the large multi-centric trials that we've had the privilege to lead here at the Marsden and ICR, and that have really changed practice for patients in the clinic. So just to orient you, the next slides have this kind of timeline. This is the trial timeline. So the year shows the year that the trial was launched, and the N stands for the number of patients that went into these trials. So those patients who have probably in the audience who had their radiotherapy before 2012 would remember that we gave treatment after surgery. We gave radiotherapy every day for 5 weeks, and that was standard of care. But then in the 1980s and 1990s, the Marsden ICR launched the pivotal START trials that then compared 5 weeks of daily radiotherapy to 3 weeks of daily radiotherapy. And the way we did it, we gave a slightly higher dose each day, but over a shorter period. And I'm pleased to inform you all that this has changed practice. So women now standardly get 3 weeks of radiotherapy, not just in the UK, but also internationally. And of course, based on that success and following on forward to see whether we can further shorten it, in 2012, we launched the Fast Forward trials. And this is comparing 3 weeks of radiotherapy versus 1 week of radiotherapy. And thanks to patients like some of you in the audience, perhaps, we recruited 2 years ahead of schedule. And this is now in the follow-up phase, and hopefully we will get the 5-year results in early next year, and hopefully then by the end of next year, 1 week of radiotherapy will become standard for women after surgery. And that is a fantastic achievement for patients. We've already shown with the Fast Forward trial that the 1 week schedule actually gives fewer acute radiation effects, i.e. the skin burn or sunburn type reactions. And so we need to test whether the late side effects and tumour control is just the same, which would be fantastic for patients. Now, the other trial just to highlight is Import Low. And so this launched in about 2007, and typically after patients have had surgery, we give radiotherapy to the entire breast to try and tackle any rogue cells that might be left behind in the breast or chest wall, and that is standard. Now, Import Low tried to see whether in lower risk patients, so those that are postmenopausal, less than 3 centimetres of tumour, lower grade, etc., whether you can reduce that, instead of giving the whole breast some radiotherapy, because we know that most of recurrences, if they do occur, either occur where the tumour was or in about a 2 to 3 centimetre area around it. So then it was testing whether instead of the whole breast, we can give partial breast radiotherapy and thereby avoid side effects of the rest of the breast that doesn't really need the radiotherapy treatment. And again, I'm pleased to inform you that this trial completed successfully, reported results successfully, and now partial breast radiotherapy is standard of care for our low-risk breast cancer patients. Now, one step further, can we identify a group of patients that are so low, have such a low risk of recurrence that we can avoid radiotherapy altogether? So this is that trial, Prime Time. It's currently recruiting, and it's a fantastic collaboration with Mitch and his team. So we are trying to see whether patients who are over 60 have less than 2 centimetres of tumour, low grade, node negative, etc., combining biology, looking at how quickly the cancer cells divide, whether you can combine all of that and identify a group of women that don't need radiotherapy at all and can just have an excellent outcome and cure rates with just surgery and endocrine treatment only. This will report in the years to come, and we hope that we can avoid radiotherapy for very low risk patients. Now, sticking with the theme of trying to improve our radiotherapy by trying to avoid late effects, and here I'll highlight cardiac or heart toxicity. So just to orient you, Alistair showed you a PET CT image. So the one on the left is a cross-sectional image of a CT scan, and the image on the right is a coronal, so sliced like that. And I don't know whether you can see it clearly, but the organ outlined in yellow is the heart. So those women who are having left breast or chest wall radiotherapy, you can see the red line is the posterior line of our radiotherapy field, and that you can see how the heart sits very closely to the chest wall and is clipped or included within the radiotherapy field. And we know that radiation to the heart causes late cardiac damage. So can we spare women this toxicity by a very simple technique called voluntary breath hold? So women are just asked to hold their breath in for 20 seconds. And you can see what happens there. The heart gets pushed backwards and downwards, and you get a nice little gap whereby you avoid all dose to the heart altogether. And now this is again standard of care. It was led here by Anna Kirby and colleagues, and now nationally adopted as well as internationally. Now, last slide, the other end of the spectrum, i.e. high-risk women who present with locally advanced breast cancers that are greater than 3 centimetres, involving perhaps the skin or the chest wall, for example, and who can't have surgery because they've either had, they've got disease outside the breast, or they're metastatic, or they don't want surgery, or despite, all the drug treatments, the tumour hasn't shrunk enough. So can we do something to make radiotherapy even more effective? So this is a trial testing a novel radiation sensitizer. So the drug, the active drug, is hydrogen peroxide. We know it as bleach, essentially. But this is an innovative concept by Japanese colleagues, whereby you mix it in a gel and you can inject it directly into the tumour twice a week when patients are having radiotherapy. And the next slide, I'll just show you, and a disclaimer, it is a patient who's had locally advanced breast cancer. So it's not commonly what we see here in the UK, but this is one of my patients who had a large fungating breast cancer. So if anybody is sort of disturbed by that, I'd suggest look away. But I'd just like to show you the results and show you how powerful radiation with this novel agent can be. So she presented like that, and we gave her the quarter called the hydrogen peroxide injections along with the radiotherapy. And 3 months on, she had a complete response. And despite her having disease outside in the lung and the breast, which then grew subsequently, that has remained in complete remission for nearly 2 years. So that's just, and we're really excited about this study because now we are going to launch a randomized trial, hopefully in the next couple of months, testing either radiotherapy alone or radiotherapy in combination with this drug. And I'd just like to say, end by saying, some of my colleagues have already said, and Mitch has said, we can't do any of this without the cooperation and participation of patients like yourself or your friends and family. And it is a huge team effort, not just with academicians, but also patients across the country. Thank you.
Am I still on? Thank you very much, Navita. It really is a challenge to get through all this on time. We've just slipped a few minutes. We're going to have a break now, so you can have a quick cup of tea, cup of coffee, a couple of biscuits. I think if we can get everybody back in here by 25 past, we won't slip very far, so thank you very much.